Good evening, and thank you for joining us. It's great to have this full room, and I can assure you that you're not going to regret it, because our wonderful team in the Barcelona office for health systems financing, we have Tamas Evitovic and Sarah Thompson, have really put together a great session on an important topic, a topic that is highly relevant and topical at the moment, which is really about securing affordable access. Why? Because all the signs that we are seeing are showing us that we are entering some very difficult times with the fiscal criteria in the EU, Eurozone, and with everything else that is happening. So now is the time to really raise our voice, and when we do so, of course, we need the evidence and the data. And again, our office in Barcelona can always be relied upon to provide the evidence and the data, even at very short notice, as it was my pleasure to be able to share with you already earlier in the day when we provided you with an appetizer. So without further ado, enjoy the session.
Thank you very much, and it's great to have support across the organization from very important people who are able to give us a little bit of strength to what we're trying to do. I'm Charles Normand. I've been asked by my friends in the Barcelona office to help facilitate this. I'm known for a few things. One is complete lack of any sympathy for people who go over on their timing, and also very unsympathetic to anyone who falls asleep in the audience. I will be monitoring that carefully. Luckily, you're not the biggest audience we've had. You're nearly the biggest, but you're by about 15% the cleverest, so I'm very happy to have you all here. The reason why we're doing this session is that we now have very good evidence and data that allows us to understand what are the consequences of badly designed, badly put together systems of healthcare finance. What we're now looking at is how can we use this knowledge to take one further step, which I think is critically important, and that is how do we ensure that when crises come, and crises will come and do come, that we don't lose the gains that have been previously made. How can we try and make the systems robust in ways that protect them from the unfortunate consequences of short-term, often poorly thought out reactions to financial difficulties? So that's what I hope we're going to get through this. We've got a very tight schedule, and we're going to try and keep to that schedule because I want the opportunities to have quite a lot of participation from the floor. So but without any wasting other time, then I'm going to ask Tamas Evitovic to come to the table and give us some of the background that's critical to the discussions we're going to have. Tamas.
Thank you very much, Charles. Good evening, everyone. 4 years ago, here in Gastein, we presented the first ever regional report on financial protection using evidence from 24 countries across Europe and Central Asia. Now we are here to present the main findings of the second regional report, which now covers 40 countries across the region, including, for the first time, all EU countries. Back then, I started with a question whether there are any countries in the European region which achieved universal health coverage. And of course, the answer was no. Unfortunately, I'm back here again to tell you that even with 40 countries that we cover now, the answer is still no, because there are always people who face financial hardship or have unmet needs. Now, what we are going to answer are those same questions. How many people face impoverishing or catastrophic expenditure, who these people are, and what drives financial hardship? Groundhog Day? Maybe. Let's see. I will present the main findings, the data, the numbers, and Sarah will share with you the story behind the figures to answer the question of how we could improve financial protection across Europe. Is it acceptable that people become poor as a result of ill health? acceptable or not, this is what we see across the region. The range is from less than 1% in Slovenia all the way up to almost 12% in Ukraine, with a median of around 2.5%, and the worst performing, and that's the most important message here, even in the EU countries, the worst performing country, Bulgaria, is at 8%. 8% of households face impoverishing expenditure out of their pocket as a result of using health services. So health systems contribute to increasing instead of decreasing poverty in these countries. The incidence of catastrophic expenditure ranges from under 2% on the left, Slovenia, Ireland, UK, Spain, and Sweden, all the way up to 20%, Armenia and Bulgaria, with a median at 6%. Now, what matters, although these are already very unacceptable numbers, but what matters, going back, sorry, is the distribution. It's always the distribution. So on this chart, what you see, the dark blue bars show the incidence of catastrophic expenditure for households that belong to the poorest 20% of the population. And then the median immediately jumps to 20%, and the worst performing EU country reaches beyond 60%, meaning that more than half of those who belong to the poorest quintile of the population face catastrophic incidents. How much out-of-pocket expenditure for different health services in the EU countries? Now we are looking only at the EU countries. What you see on this chart is the dark gray part of the bars are public financing for those services. The light gray is for voluntary health insurance. Note how small that is. And the colored part is what stands for the out-of-pocket expenditure for these services. Inpatient care, almost fully covered. Outpatient medicines at 40% out of pocket. And dental care and medical products, almost 60 or around 60% out of pocket. What drives financial hardship? We need to look into and zoom into the incidents that I showed earlier with those blue bars. Now, ranking countries again the same way. On the left, you see the good financial protection, low incidence of financial hardship. On the right, the high incidence of financial hardship. And then what we see in terms of the composition of the services that are responsible for financial hardship is that on average, the red stands for medicines, and then you see also dental care and medical products, more on the left where the financial protection is stronger in those countries. But again, what matters is the distribution. So let's look at the countries, the population of the poorest quintile. Can you forward, please? Because my clicker doesn't work. And then once we look into the composition of services that are responsible for financial hardship for the poorest 20% of the population, this chart becomes almost everywhere red. So the message is that for poor people, it's medicines that drive financial hardship. Poor people prioritize medicines over other services and products. The other services and products, like dental care, become unmet need for them. Poor people also delay seeking health care until the point when it becomes so severe that they need hospitalization. And what happens in hospitals, suddenly medicines are covered. Why is it that people who are getting their medicines while they are inpatient, hospitalized patients, they walk out of the hospital and suddenly the medicine, the very same medicine, becomes a significant cost of the treatment? I think we need to think about these very fundamental mistakes we do. Of course, the message is not that, oh, what a great idea now to deal with the pressure, the fiscal pressure. Let's introduce user charges for medicines, even when patients are in the hospital. That's not the takeaway message. The takeaway message is that most of the services that are responsible for financial hardship, especially for poor people, are taking place for treatments at primary care settings, either at first contact or for chronic conditions when they get back to the primary care leaving the hospital. And let me finish with the chart that shows the correlation between out-of-pocket payments as a share of current spending in any country, which is a data that is available to any country. Practically, you don't have to have household budget survey, and the catastrophic incidence on the vertical. There is a strong correlation, but what you see here is that as long as countries keep out-of-pocket expenditure below 15% of total spending, the incidence tends to be relatively low with small, modest variation across countries. Once it's more than 15%, the incidence steeply rises and the variation is huge. The variation suggests that the protection mechanisms for poor people make a huge difference. But at the same time, what needs to be understood clearly that public financing is critical for providing good financial protection. 15% is not a magic number, but a good proxy that everybody should take away, that as long as you can keep it under 15%, it's quite likely that financial protection is very strong. I think what is the first question here, as I started, is it acceptable that people become poor as a result of ill health? Is it acceptable that some people don't have umbrellas? They are not covered. And that's where we are going to start asking the question from you in the audience. Can we have the Slido question up there? And I hand back to you, Charles. Thank you very much.
Thank you so much. You're all experienced on the Slido, so you can do this pretty quickly. The question there is, if you don't pay social health insurance contributions, what should happen to you? Either A, you should lose access to social health insurance benefits, or B, you shouldn't lose those when the tax agency should pursue you to try and recover the contributions you should have made. Can you all vote on this? I see there's a big enthusiastic group for you should lose your benefits. That's there must be slight variation between Gastein attenders and the rest of the world then. But that's very, very interesting. Oh, just when I thought it was safe to say nice things about you. Okay, so 82, 18, 84. That's a few more people coming on the other side of that. This is interesting. Okay, have you all voted, all those who know how to use mobile phones, all the under 40s in the audience? Okay, right, now, can we have the second question? If you don't pay your income taxes, what should happen to you? Should you lose access to your children's education and healthcare and other publicly financed services, or should the tax agency pursue you? There's, I think, some small sample problems appearing in some of this, but we're beginning to settle down there. Now, the obvious point that we're trying to get at with these questions, I mean, you're all clever enough to work out the obvious point. Is there a reason why healthcare financing for public or publicly mandated healthcare should be treated differently from, say, your children's education, in the way in which we either do or do not link access to whether or not you've paid your contribution? We can come back to this later on, but I think it's pertinent because it comes back to 2 points that Tomáš was making in his presentation. One is that user charges affect people's ability to access care, and the other is that user charges increasingly have the effects of impoverishing people, particularly people on low incomes. So there are these two sides of this question. But I'm now going to ask Sarah to give us a little bit of an update from their work on how the different ways in which we pay for care have different effects on different parts of the population, using the latest evidence we have. So thank you, Sarah.
Thank you, Charles. I'm hoping the clicker works, but if I start waving, it's because the clicker doesn't work, and I'm waving to my friend Sarah over there. Thank you, Sarah. Tomáš has given you a very quick overview of the numbers in our study, and what I want to do now is just give you a very short version of the story behind the numbers. in our study, we look very carefully at the relationship between financial hardship on one hand and coverage policy on the other hand. And coverage policy is the way in which health coverage is designed and implemented. And we focus on three aspects of coverage policy: the share of the population that's covered, the range of benefits that are covered, and whether or not people have to pay user charges for services that are covered. We look at coverage policy so carefully because it's a really important determinant, not just of the level of out-of-pocket payments in a health system, but of the distribution of out-of-pocket payments across different groups of people in a population. And one of our key findings is that gaps in coverage affect different groups of people differently. And I just want to illustrate that with the example of dental care. So Tamar showed you the drivers of financial hardship across countries. This is showing you the picture in one country, but this is a pattern that is repeated within countries across many countries in our study. You see here that dental care mainly drives financial hardship among the richer quintiles in the distribution of the population. And one of the main reasons for this is because poorer households are much more likely to not be able to afford to access dental care and to experience unmet need for dental care instead. And you can see here that unmet need in the poorest fifth of the population is around 8% reporting unmet need versus under 2% among the richest fifth of the population. Thank you. I was wondering where the slides had gone to. Can you just keep the images there? Thank you. That's it. Perfect. So it's very, very important to understand the different impacts of gaps in coverage on different parts of the population. And this is just an example here with dental care. Thanks. Next slide, please. So what causes the gaps in coverage in European health systems? Well, many health systems in our study are addicted to bad ideas. And unfortunately for us, coverage policy is just full of these bad ideas. This is not necessarily because policymakers are unable to understand evidence. Most often it's because of path dependency. Things have always been done this way, and things will always be done this way, and to change is difficult. Before I talk about the two addictions that I want to focus on today, just two quick points about the importance of inequalities. The first one is that inequalities really are a problem when it comes to affordable access to healthcare. The bad ideas that we're going to talk about today really hit people with low incomes the hardest, and this pain is only magnified when there's an economic shock on top of it. The second point about inequalities is that they can be part of the solution. We see from our study that progress is possible if countries are willing to do two things: if they can overcome path dependency and if they can adopt an approach known as progressive universalism. And what this really means is trying to reduce out-of-pocket payments first for people with low incomes and for people with chronic conditions, being very focused in reducing out-of-pocket payments for these people who are at highest risk of financial hardship and unmet need for healthcare. This also has the advantage of building resilience into health systems at the same time. Okay, so now the first bad idea of today. This is linking entitlement to payment of contributions. In European health systems, there are two ways in which people can be entitled to publicly financed healthcare. The first is on the basis of legal residence, and these are the columns in blue here. The second is more complicated. This is where entitlement is linked to payment of usually social health insurance contributions, and this is the red columns that you see here. In these countries, many countries with social health insurance schemes, in order to be entitled to social health insurance benefits, you have to pay contributions yourself, or the government has to pay on behalf of you, and this is what happens for children. The government usually pays for children. If we look at the countries on the left here, these are countries that report covering 100% of the population. And you can see there's a nice mix of blue and red in this group here. But if we look at the countries on the other side, on the right-hand side of the chart, you can see that where there are significant gaps in coverage, and we would count anything over 1% of the population as a significant gap in coverage, then you see that these countries are overwhelmingly red. These are overwhelmingly countries with social health insurance contributions. So linking entitlement to payment of contributions leads to very visible gaps in coverage. They also exacerbate inequalities in affordable access to healthcare because they mainly affect people in relatively vulnerable situations. In this case, people in precarious work, people in the informal sector or people who have unstable or insecure jobs. And it is also inefficient for the health system because people who don't have access to social health insurance benefits forego care or self-treat with medicines or use emergency services, which is not a good use of resources. What's the relationship between this and financial hardship? No, go back one. So if we map the incidence of catastrophic health spending onto this chart, if you look at the left-hand side of the chart, you can see immediately that population coverage is not a good indicator of financial protection, because there are some countries here that report covering the whole population and yet have very, very high levels of catastrophic spending on health. If we look on the other side, on the right-hand side, you can see that among these countries, it does seem as though it's quite hard for these countries that have significant gaps in coverage to achieve really low levels of catastrophic health spending. So what we might plausibly conclude from this is that covering the whole population is important. It's probably a prerequisite for financial protection, but it's not a guarantee. In other policy areas, other gaps in coverage, like gaps in the benefits package, gaps caused by user charges, are also an issue. Let me just wrap up. Next slide, please. Let me just wrap up this bit. So linking entitlement to payment of contributions, it's a bad idea because people are at high risk of losing their entitlement to publicly financed healthcare at the moment when they need it most, when they're losing their jobs, when they've been unemployed for a long time, when their incomes are falling and they simply can't afford to pay contributions, undermining their resilience, but also the resilience of the health system. We're trying to get countries to move away from this path-dependent policy because there's just no evidence to suggest that using the health system to address what is really a tax problem is an effective strategy. And lastly, we think that progress is possible, and we have two good examples from our region, from France and from Israel, countries that have always had social health insurance schemes, but have managed to break this link between entitlement and payment of contributions. In both of them, the basis for entitlement is now legal residence, and yet these countries still maintain their social health insurance schemes. It's possible to have social health insurance, but to have entitlement based on residence. And I think the question for debate now is whether other countries in the region are willing to follow the lead set by France and Israel.
Thank you, Sarah. Now, rather than being just despairing about this, we're going to try and look at a number of case studies from different countries and see if we can begin to unpick some of the ways in which we can handle these dilemmas that Sarah has discussed a little bit better. Maris Yessa is going to be talking a little bit about some of the experiences that are important in Estonia. And if I can just start off, I mean, there's been a problem of getting full coverage of the population in Estonia, and it's somewhere around about 4% of the population haven't been covered, but perhaps more seriously, a very high proportion of the people in their 20s have not been covered. And again, this is coming back to people who are probably in more precarious work or more part-time work. I wonder if you could give us a little bit of insight into what are the challenges of trying to change this, and what are the difficulties that have been encountered in trying to do that.
Thank you. You did most of my introduction already for me. All of you who are in the audience, we all concentrated probably on how our own country looked on these graphs that were just shown. And my own country, Estonia, was on the left side. As Charles said, we are not currently covering everybody. The coverage has been around 95, 96%. So we are not doing like the worst. However, legislation would say that we should be doing better. And so what is the issue? Estonia has a social health insurance system based on payroll tax. The tax is paid by the employers, and we are not so cruel. We don't take the insurance away from employees if the employer has failed to pay taxes and is in arrears. I must admit, in the 90s, we were so cruel. And the health insurance tax was the best complied tax. of all of the Estonian taxes. However, we came to reason, and from 1999 it's not that anymore. So employees have the coverage even if the employer is in difficulties. We do cover children, students, unemployed, all of the possibly vulnerable groups. So what is the issue? That we still have 4 to 5% uninsured at any given day almost. And it is because exactly the nature of work has changed from what it was in the beginning of 90s and the middle of 90s, with more of the project work, irregular work, with young people choosing not to be in permanent employment, but rather have these spouts of intensive project work and then taking off for 3-4 months to do their hobbies. We haven't been really kind of sitting and observing the situation from the health sector side silently. We have been proposing for 10 years already several options of how to broaden tax base, how to move away from the payroll tax, and at the same time also broaden the coverage and insurance entitlement. And this is where the path dependency that we set in the 90s kicks in. And it is to my surprise, the finance authorities who are still our taxation agency, who are still kind of in their mindset, kind of stuck in the mid-90s, and argue that if we would broaden the tax base, if we would broaden the entitlement to insurance further, then we would start losing taxes. I have more confidence in the taxation agency and their capabilities, it seems, than the leaders of the taxation agency themselves, which is odd. We know that path dependency can be broken at times of crisis. And in Europe, we have been through crises for the last 3 to 4 years. We cannot ask for a better real-life example of why it is necessary for people to have early access to diagnostics and treatment than we got during the pandemic. All of us provided free of charge testing. All of us got people to the doctors and treated as quick as possible. So now we are hoping that perhaps relying on the real-life examples brought by the pandemic, we might have another chance of being more successful in the debate than we have been so far. But what is also necessary, I have 18 seconds left, we shouldn't go only with health arguments. We shouldn't go out only from the health sector. We have to build bigger alliances, taking on board exactly these young people who are interested in their intermittent working, the creative community who is very much in irregular employment, and so forth. And with 10 seconds in the minuses, I'll conclude from at the moment.
Okay, now we've got a few minutes available now for questions and comments from the audience. There are microphones around, and you can either raise questions or issues that have come out of the presentations, or if you prefer, you could also make some comments about your own country in terms of things like the path dependency and the questions of why things have not always been the way they want. Do we see any hands? Yes, we have a hand here, and we have another hand here.
Thanks, Charles. Thanks, everyone. Great session. Magda Rosenmöller, Jesse Business School. The question would be to Thomas. I'd like to see, you talked about the medical products, and then you explained it was medicine and medical devices. I'd like to see, is there any change there? Is it like mainly drugs, or would this also now apply for other medical devices that could be apps, etc.? And what is the impact, or is there any thinking about about if they would be covered publicly, would that really make a difference in sustainability of health systems? Thank you.
As always, you know, if it would be covered publicly, would it make a difference in sustainability? The question is how we understand sustainability. What's the objective we want to achieve? If the objective is that the public finances are in balance and then spending less is a good thing, then of course it's not going to help sustainability. But the other point that you raised, what medical products actually cover, I mean, here we are following the same standard approach in all countries using household budget survey, especially in the EU. That's quite, you know, good and standardized approach. But the country you're coming from, actually, not your original but current, Spain, actually just shifted not long ago how they count some of the medical products for dental care, and then that's why we were puzzled by the change. So we do have to monitor that very closely, what's counted in and what's not counted. Of course, the answer is that if we increase coverage of those medical products, then the utilization will go up, because those who are most in need are those who are actually facing unmet need as a result. So once it's covered, they will use it. So I think it goes back to the fundamental question. What are our objectives? And then if health is an objective and improving health is an objective, then practically it's not going to hurt sustainability. You know, there are no countries which went bankrupt as a result of covering more services and spending more publicly.
Martin.
Yeah, Martin McKee. Methodological question in the household surveys. How do you deal with the issue of those groups that are systematically excluded from the surveys and are also more likely to be excluded from coverage? Undocumented migrants, people living especially precarious existences, homeless and so on. I think we've talked about it before, but I think just for discussion it's interesting to consider it.
Sarah knows more. My response to this question that I would turn to Martin McKee for advice.
Sarah can turn to Martin McKee for advice. Do you have any further things to add on that?
Just to say that some of you may have been feeling very, very smug because you're sitting here and you don't come from a social health insurance scheme and your country reports covering 100% of the population, but actually what we don't see, the much smaller gap in coverage, the much less visible gap in coverage is for undocumented migrants. And very, very few countries in Europe provide good access to healthcare for these groups of people. Spain is one noble exception to this rule. In response to your question, Martin, we don't have data because these people are underrepresented in the surveys that we use, but we look very carefully at coverage policy, at the entitlements for undocumented migrants, and that way we can identify at least where the gaps are, even if we can't see what the magnitude of that gap is.
I mean, I think the basic answer to the question, Martin, is you thought things were terrible, but they're even worse, is the difficulty you have here. Because I think, I mean, there are some really difficult questions, I think, around how the most vulnerable populations, even those who are not vulnerable because of being migrants or disadvantaged in those ways, there are always going to be those sort of difficulties. We've got a question over there and another one at the back. So if the running microphones can run. I said run, I didn't say wander.
Thanks very much. Mark Hennessy, Department of Health, Ireland. I think, Tomas, your findings are really interesting in terms of, you know, how no access to these primary care services is ultimately leading to hospitalizations and sort of an increased cost in the acute care system. Do you think that this is a problem of sort of optimization or measurement as much as it is about a question of whether or not we should cover these groups? As in, if we were to provide a more extensive social security net for primary care access in these contexts, is that actually going to lead to an overall decrease in the cost of providing healthcare, you know, across the system as a result of a reduction in acute care expenditure? Or do you think that we still have to compensate, that you know, those avoidable hospitalizations may be one component, but not the whole story? Thanks.
A quick response on that?
Wonderful research questions that we would need to explore further. But I think the fundamental point that we are making here is that just because medicines are not covered, even for some chronic conditions, when patients have to pay 50% of the price for poor people, that's unaffordable. And that's why we see compliance problems. For chronic conditions, they are not taking their medicines. And then if you go all the way in the eastern part of the region, you actually find medical practice where the doctor would advise the patient with high blood pressure, take this drug only when you are in crisis, because I know you cannot afford to buy and pay and have it as prescribed, which is normally, of course, to take it every day. So I think simply by covering more generously at least those otherwise relatively low cost, but for poor people still high burden medicines would reduce the delaying of seeking health care and as a result, the more intensive and more complicated situations. Whether it overall would reduce expenditure, that I cannot tell.
Well, I think it wouldn't necessarily reduce overall expenditure, but it might reduce inappropriate expenditure and wasteful expenditure. I mean, the overall expenditure depends on what those overall controls are that reduce spending, but this will probably put people on a better pathway of care than they would otherwise be. But as Tomáš says, if you'd like to give us a big grant, we might consider whether we can explore that in more detail. We'll have one more question near the back.
Good evening, everybody. My name is José María Castellano. I am coming from the Quality and Assessment Agency from Catalonia in Spain. And well, congratulations for the presentation. It was fascinating, the topic of the path dependence. And well, as you know, path dependence sometimes is an endogenous as well factor. And well, in relation to that, you mentioned that two countries, Israel and France, were able to move and to break this type of path dependency. Well, what are like the main facilitators for this change, and what are like the main barriers that make that some countries continue in the path dependency? Thank you.
Sarah, quick response.
Just a quick response on France. In France, they were anticipating the challenges to sustainability that would come from not being able to cover enough people when entitlement was linked to payment of contributions. And in France, they were particularly concerned about young people who were unemployed in unstable work. And because they saw that there was going to be an issue, they took action, and it was really a concern for youth unemployment that triggered that.
Thanks very much. Now, Sarah, we've been talking a little bit about how user charges have particularly difficult effects in certain areas. I just think, though, it's worth us looking in some detail. In my view, user charges are almost always a bad idea, but you can have a bad idea and do it relatively well, or you can have a bad idea and do it very badly. And Sarah's going to give us some insight into how a bad idea can be made very bad or only fairly bad.
Thank you, Charles. Sarah, great. So this is the second addiction to a bad idea, and as Charles said, we're going to be talking about user charges. From this chart here, you can see for the 40 countries in our study that almost all of these countries have user charges in one form or another, and I think it's the form that is very important. What's surprising, though, is that so many countries have user charges when there is such a large and consistent body of evidence that shows that user charges are really not an efficient instrument. They really undermine efficiency in health systems. They prevent people from accessing care that we want people to access, and they reduce adherence to medicines with negative impact for health outcomes in some cases. So they're really not an efficient instrument, quite the reverse. What we do see, however, is that countries do recognize this to some extent, because all countries try and protect some health services from user charges. So countries do show some recognition of the harms that user charges can do. You will see from this slide that less than half of the countries in the study apply user charges to emergency visits or primary care visits. But I think what's ironic, and Tomáš alluded to this earlier, it's ironic that countries go to some length to protect primary care visits from user charges, But you see from this chart that the minute you get into a primary care setting and you have treatment in primary care, whether that be medical products or dental care or outpatient prescribed medicines, then countries feel quite relaxed about whapping user charges onto the users of those services. So efforts to protect primary care visits, but not extending that to treatment in primary care. What's the relationship with financial protection? How does it is it a problem for financial protection? And if so, what can countries do about it? This chart here shows you the incidence of catastrophic health spending, and I've broadly divided the countries into two groups. Quite low levels of catastrophic incidence on this side and higher levels on the other side. Sarah, what we see when we map the design of user charges policy for outpatient medicines onto financial hardship across countries is again that countries show recognition of the damage that user charges can do, and many countries try to protect people from user charges for outpatient medicines. And the countries on the left use a wide range of strategies. First of all, they have exemptions, often based on income, so exemptions for people with low incomes, and sometimes also for people with chronic conditions. For these two groups of people, it just makes no economic sense to have user charges at all. But exemptions, not everybody will benefit from these exemptions. So many of these countries also have caps on co-payments, and this builds in an element of financial certainty, especially if it's linked to your income, as it is in Austria and Germany. So you know that you'll never have to pay more than 1% of your income through co-payments. It's a very powerful protection mechanism. Some of these countries, not very many, but some of them also use low fixed co-payments, and this enhances transparency and financial certainty. You know in advance how much you're going to have to pay for your prescription. The other strategy that some of these countries use is private health insurance. And we've put it in yellow because we think it's a very challenging policy instrument. In order for voluntary health insurance covering co-payments to be protective for people, you have to make sure that almost the whole population does have coverage of voluntary health insurance. And only 3 countries globally have managed this: Slovenia, Croatia, and France. And it's been really, really hard work for the governments in those countries. They've had to massively intervene in the private health insurance market. And in France and Croatia, they've had to make private health insurance free for people with low income. So there's a cost to the government, a financial cost as well. So it's not an easy policy instrument. We don't think it's very generalizable to other countries in the region or beyond. In the countries on the other side, Sarah, protection mechanisms apply. So again, these countries do recognize that user charges are potentially damaging to people, but the protection's often not adequate or effective. So for example, they have exemptions, but these exemptions are just for some health services and not really linked to people's income. So they're not exempting people with low incomes. They don't have caps, or they have caps, but they're set too high to really be protective, or they just apply to a very specific set of services. And the other thing that we see in these countries is very heavy use of percentage co-payments. These are co-payments where the user pays a percentage of the cost of the medicine. Purchasing agencies love this because it shifts financial risk onto the users of health services. You pay the percentage of the price. There's less incentive for the insurance company or the purchasing agency to think about controlling the prices of medicines. They're also really unfair because if you are unlucky enough to have a condition that requires an expensive treatment, you will have to pay more of the cost than if you're lucky enough to have a cheaper condition with a cheaper treatment. Next slide. So I think the message here is that co-payment design really matters. As Charles said, even if you have user charges, if you recognize the damage that they can do, you can design your user charges policy very carefully to protect people and to lower the incidence of catastrophic health spending through exemptions for low-income people, people with chronic conditions, caps, and replacing percentage co-payments with low fixed co-payments. It's also very important to remove administrative barriers so that people can actually access the protection mechanisms in place. And finally, it's important to monitor what's happening and adjust if necessary. So you can have user charges, but if you design them very, very carefully, you should be able to reduce or minimize financial hardship and unmet need. Okay, my last slide, wrapping up the 2 bad ideas that we've talked about today. answering a little bit the question of the person in the audience there. What is it that makes progress possible? Well, we identified 3 factors, and the first one is evidence and analysis. It's really important to understand where the inequalities are in affordable access to healthcare, and they are there, but also to understand what's driving them. Second, progressive universalism. Reducing out-of-pocket payments first for people with low incomes and for people with chronic conditions, because these are the people that are really at most risk of hardship and unmet need. It's also a really good strategy when you have a budget constraint, because it allows you to target your resources to where they are most likely to be effective. And lastly, it builds resilience into the health system and for households. And then my third factor, overcoming path dependency. Many of these bad ideas reflect historical factors, they reflect politics, much more than they reflect evidence. And we think that just because you've always done something this way doesn't mean that it always has to be done this way. Countries can understand the evidence, and some of them can be brave enough to actually act on the evidence too. Thank you.
I was just thinking when we were seeing the slide about private insurance, voluntary insurance to cover co-payments. In Canada, if you're a private individual buying the supplementary insurance, studies have shown that less than half the money you pay ends up at the other end paying the co-payment. So you actually end up paying double the amount you would if there weren't any, if it was just part of the tax system and it was you were just paying through that. And on the whole, I'm very sentimental, but I would prefer not to be funding lawyers and accountants as the primary purpose of running this and having high transaction costs. But I'm not the main show here. The main show now is going to be a panel that will be talking about some of these issues around the use of user charges. So if I ask Katri and Stefan to join us on the platform, we are going to have some cases of Finland and Estonia and what's this country we're in at the moment? Is it and Austria. And so if I just start off with you then, Katri, can you talk a little bit about how Finland has responded to budgetary pressures and how this response has had various different consequences? I won't go any further because I was criticized before by answering the question before by asking it. So Katri, over to you.
Thank you, and thank you very much for having me. It's really an honor to be here. Yes, in Finland, so in the government sought savings for 2017 in the aftermath of financial crisis, and they were also seeking savings from the pharmaceutical budget. And as part of those reforms, co-payments for type 2 diabetes medicines were increased. So this group of medicines was targeted because it had been under scrutiny because of rising costs. This was due to both increasing prevalence of type 2 diabetes, but most importantly because of the therapeutic shifts towards using newer and more expensive medicines, as there were, during the preceding decade, quite a lot of new diabetes medicines that had entered the market, and they had become standard of care in Finland. They were quickly uptaken to clinical guidelines and to the reimbursement system. So what was done was that the government changed, as we just heard, from a fixed low co-payment to a percentage-based co-payment for type 2 diabetes medicines, which meant that those patients who were using the newer and more expensive medicines faced increases of hundreds of euros per year in their co-payment expenditure, despite protective mechanisms which we have in place. We have social assistance and annual ceilings and so on. So a number of studies has been conducted in Finland to evaluate these effects, and I'll quickly go through them, not in detail. They're all published, so there's more details available. Well, for instance, the consumption of type 2 diabetes medicines just slightly decreased. There was no respective increase in the use of insulin. Then in terms of clinical outcomes, one study found an increase in the glycosylated hemoglobin level, suggesting worsening glycemic control, which in the long run, of course, risks diabetes complications. And this was more pronounced among the patients who prior to the reform used these newer and more expensive medicines. In terms of economic outcomes on households, there was an increase in the use of social assistance. That's the last resort, very strictly means-tested social benefit in the Finnish system. And it's considered a negative effect because it's a sticky kind of benefit. So once families and individuals end up on social assistance, it's really difficult to get out because of incentive traps. There were also patient-reported outcomes. So among diabetes patients in longitudinal surveys, there was increase in financial difficulties in buying medicines. There was worsening satisfaction towards diabetes care, more pronounced than among those who had financial difficulties. In even a broader cross-sectional or repeated cross-sectional surveys, there is a suggestion of increasing skepticism among the population towards the fairness of the reimbursement system. So the evidence overall is aligning with what was previously known about the negative effects of co-payments. And so a more explicit method of rationing would have, of course, been to introduce the new medicines more carefully. But at this point, they had already become the standard of care. In a wider sense, in Finland, it was acknowledged that a better way to pursue cost containment in the pharmaceutical sector would be to promote more responsible use of medicines or more rational prescribing. But all such measures were awaiting for a larger scale social and healthcare reform, which had been in the making for a decade at that time. There was no political consensus of how to do that. So the government sought these quick fixes, something in between while waiting for the bigger reform to happen.
Thank you. I think there's a very important moral there, that the correct time to do something is always last year or next year. It's never now. And there's always a good reason for doing a quick fix when a more substantial, thoughtful approach would have been more appropriate. But we live in a world of quick fixes. But I'll come back to you, Maris, again, if you're okay. And the positive story from what you were saying earlier. We were really not being very nice about your problems earlier. We can be very nice about your solutions now. Would you like to tell us a little bit about them?
Thank you. Indeed, I'm really happy that I have another story to share with a more optimistic note, and it is about when the values, technical capabilities, and political will come together at one point in time, and what can be done rather quickly. The Estonian health insurance has been reimbursing prescription pharmaceuticals from very early on, which is not necessarily the case in all of Eastern European countries, which started economic transformations in the early 90s. However, we were aware that people have high out-of-pocket spending still, and some people, especially those who with multiple chronic diseases, are at risk of catastrophic expenditure, or they don't buy out their medicines at all, at least not in the quantities needed. In 2002, we introduced a supplementary benefit for these people who reach certain thresholds in out-of-pocket spending, so their had 50% additional benefit, and then another threshold after which there was even additional benefit. Firstly 75% reimbursement, later changed into 90% of reimbursement. And this is how we try to kind of then handle the risk of catastrophic expenditure. At the same time, our pharmacies and health insurance fund established their automated financial data exchanges, and Estonia introduced e-prescription in the middle of the first decade of 2000s. Currently, almost all prescriptions in Estonia are e-prescriptions. And those technical capabilities allowed us to think and introduce of an automated reimbursement system for these people who have reached the thresholds in their out-of-pocket expenditures, because in 2002 it was introduced as a retrospective reimbursement to the people after submitting their invoices and all the rest of the papers to the health insurance fund. So from 2018 there is an automated system in place with no administrative steps from the persons needed at all. You just go to the pharmacy, and the pharmacy already knows from their systems what the level of co-payment has been, and the additional reimbursements with reduced co-payments kick in. And what has been the impact? When previously, before the system with retrospective reimbursements, approximately 1/3 of people actually applied for the reimbursement, and we know that some people did not buy their medicines at all. Then, of course, with the automated system, it's 100%. Out of all of these prescriptions, reduced co-payments applied to 0.4% of people previously. Now it's 15.6% last year. But most importantly, when in 2017, before the changes, number of people spending more than 250 euros a year was 24,000. Estonia is a small country. Then after the changes in last year, the number had decreased to 1,000. So we are, with the using the capabilities that were there, we are able to provide better financial protection for people. However, with only the civil servants and the people in the health insurance fund, it would not have happened. It needed a politician who set his heart on really addressing financial barriers and decreasing the financial burden on people. Thanks.
I think there's a particularly important message there that keep it simple, make it easy to use, it will make a huge difference. Now, Stefan, Austria is a hugely successful, prosperous country. It cannot possibly be the case that there are budget constraints or worries in Austria, are there? Would you like to tell me a little bit about the emerging issues around budget constraints and the possibility of moving towards other ways of raising the required money?
Thank you, Charles. Yeah. Also from my side, and thanks for the input from that we heard earlier, and also the presentations, because I think really we need to go into detail when we discuss financial protection, and I think that was again shown impressively. So when we discussed the Austrian case, I found it always quite interesting, because we always talk about the high health expenditure in Austria, which is true. But typically, we do not talk about the high level of private spending in that regard. So if we look that we have a long tradition of around 3/4 of public spending and 1/4 in private spending in health expenditure. And we saw that also earlier in the graphs where we all tried to find our countries, I guess, as Maris, you put it nicely. And I think looking into some of the faces, that was actually really the case, because you want to see where do you stay. And Austria is one of the countries with quite a high level of out-of-pocket payments, but then on the other hand, mechanisms in place protecting then the poorest households. And for us, that was also again a reason now in the current discussions on healthcare reform that we need to be very careful in that regard. So typically, if we discuss the main mechanisms, Austria performs quite well. So there's not a high level of unmet medical need, and also not too much catastrophic spending for health. And particularly not in medicines. But if we look into the current discussions, and I think Natasha already mentioned that, we do see this increasing pressure on our budgets, and also after the COVID crisis, where everybody had the feeling that actually health received all the money in the world, pretty much, even though it was approximately, again, 25% going into health, and it was firefighting, and most of the other expenditure that the state had to follow was going into other sectors. And now also there is the increase of pressure due to the price, the inflation, the war. So it's actually and I would share that that it's more and more important to protect and strengthen our public health system. In Austria, there is no intention by anyone, I would argue, or almost by no one, to increase out-of-pocket payment or to shift to private. What I'm more concerned is that it's an implicit decision by not taking decisions to really strengthen the public health system. So if we do not manage now to strengthen the public health system, to be there when the population is in need, then typically we see, and this is happening also for some time and also in some countries, if you look into the outpatient sector, if you look into some areas where we have more and more private physicians playing a bigger role in the setting. And this is the result of our decisions, and sometimes the result of not taking decisions. And this is why we find it so important in that process to secure the budget that allows for the strengthening of a healthcare system that is based on solidarity, because we know that really protects and also not only the population of catastrophic spending on health, but also the solidarity in the system, and then has a much bigger impact in the end. And this, I think, comes back to a question that we discussed quite in some of the sessions already. We need the trust from the population that we are able actually to deliver when people are in need of services. And if we risk that this is not certain anymore, I think that is the difficulty. And I'm convinced that we also need the trust of the health workforce, that we will be there and changing the way of providing care so that it is sustainable, and also within government. I think we did not cover that enough, because that is also our experience at the moment. We need the trust also from our partners in finance, but also in other sectors of government, that actually we really need a strong public health care system for prosperity, because that helps us then to keep, and this is also Tamas and Sarah, you mentioned that this proxy of 15% out-of-pocket payment, we are clearly above that in Austria. At the same time, we need to make sure that that we don't get closer to even the 25 or above, because I think that no matter what mechanisms you have in place, they will not be sufficient. So what I really would take away, first of all, from the discussion so far, is that I would kindly ask you to keep on this important work that helps then in policy making to really look into the details, and particularly in times with increasing constraints. And if there are shifts towards more out-of-pocket payments, to follow those important measures to avoid then the most catastrophic impact on households. But altogether, I think we need to be strong in convincing that actually it's not efficient to shift to out-of-pocket payment, but it can be a reaction due to non-taking action. I think this is something we need to make sure that we take the proper action to avoid those shifts that might come otherwise as a reaction. So this is pretty much where we stand I would love to have then the finalization, but the minister told it a couple of times. At least he managed to argue for additional 2 billion in the Austrian case. That's quite a lot of money, 1 billion for health. And it will really be then the question, can we convince also our partners that we should follow this way and that we need to introduce structural reforms to be able to avoid those really not wanted patterns in health. Thank you.
Thanks, Stefan. And I think there's some really important points coming out of that, not least the effects of non-decision making, the effects of doing nothing and thinking it's all going to be fine. And my experience is it's usually not. Usually if you just sit on your hands, you find your hands get sore and nothing good comes of it. So, I mean, I think there's some good lessons there. But the other good lesson really is if you're in a position where the current current use of user fees is doing relatively little damage, be very careful not to move to one where they do a lot of damage. And this, I think, comes back a little bit to the theme of this session, and that is, if we are in a situation where we are really resilient to these shocks or difficulties, under those circumstances, you can manage these crises reasonably well. But if the crisis comes up and bites you when you're least expecting it, then you'll often make quick, inappropriate and harmful decisions, and it can be difficult to unwind it back. But now I can take any questions or comments from the floor. We have a hand here, we have another hand here, so, and we have a hand over there. So that's the first three. I will look for other hands in a moment after that.
Claudia Wild, Austrian Institute for Health Technology Assessment. I'm really wondering whether we can discuss this topic here without talking also about over-medicalization or overspending in some areas. And maybe the podium can give an answer to how countries that have an essential benefit catalog, benefit basket, deal better with those topics. I don't think that we can have disassociated discussion without talking about essential medicine and unessential nice-to-have medicine.
I think there's some very important issues around the need for explicit rationing systems other than rationing by user fees if we're going to avoid getting into this space. But any quick responses from the panel other than throwing your hands up in despair? Yes, he threw his hand up, but not in despair.
Not in despair. I think you're right. This is an issue to address, but not through co-payments, because that shifts the decision to the patient, that the patient has no clue. The patient turns to the doctor for advice. So our target should be the supply side, not the demand side. So it's very unlikely that, especially those who are most vulnerable, the poor people, those with multiple chronic conditions, that's not where we see these unnecessary or not non-essential utilization of services. So I think that's the key here. Who are we targeting with the policy instrument at hand? And what we've been discussing here is that the demand side, having the patients to decide whether it's needed or not, that's not necessarily effective.
I mean, Katri's point earlier I thought was really interesting about this, because something became normal practice without a full evaluation process to do exactly what you're describing. Do you want to say a couple of points on that?
Yes, I think, well, these, for instance, in the Finnish case, the newer medicines, they had been already approved by the reimbursement agency, so they were considered cost efficient in relation to other therapies. So, but when the co-payment increases, then of course it becomes more important criteria in choosing the treatment for the patient. So it is unlikely that that kind of rationing will lead to efficient allocation of resources because of the socioeconomic gradient of health, which also, of course, exists among diabetes patients. So restricting the newer medicines that apparently are more effective as the health systems are willing to pay more for them, restricting them to the wealthiest of patients is not likely to bring the most health benefits.
question here.
Real quick to the colleagues of the WHO, when it comes to innovative therapies, they are oftentimes not covered yet by universal coverage. And specifically people that try to get every treatment possible and don't find a solution, a therapy on common market, are really willing to spend a lot of money in order to get the treatment and have maybe important out-of-pocket expenses. And I was wondering, is there any statistics on the hardship that this could create and also policy solutions that come up? I mean, there's gene therapies and other come up that are very expensive therapies and people are willing to pay them without coverage. Thank you.
Sarah or Tamas or anyone?
Pointed at me that I'm the boss, so these are the difficult questions I have to address. So no, the statistics is not there, and I think this is something that should be explored further. But in general, we are dealing with household budget survey data. It doesn't necessarily tell us, what was the condition. But given the frequency of these cases and given the frequency of those more multiple chronic conditions, which can be traced actually, that, what is it that medicine is for, what we can see is that mainly this is not the driver of financial hardship when we look at the whole population. Of course, this is a source of financial hardship for those individuals who are seeking all sorts of care which are not covered yet, but just in the hope of something that will be effective. But I think this is something, and I've been raising this, we need to dig deeper, but the available data sets that would allow us to link it with the distribution in the income distribution, the poorer and richer households, do not allow us to define what that was actually for. The good thing with dental care, at least, that's there, unlike other diseases for which we just have the lump of medicines as an answer in the household budget survey.
Okay, we have a couple more questions, perhaps one here first.
Good afternoon, Francisco Moran, Portuguese from European Union of Doctors. I have two questions. The first one is about user charges. And is it a bad idea when user charges is sold as something not to finance the health system, but as another thing such as moderating access or educating people about the cost? Can it be a bad idea that they can fail at all domains, like not properly financing, not reaching its objective, and also creating an additional burden? Or there is a role for them being used not necessarily with the main purpose of financing? And my second question is regarding your graphs between the poorer and the richer. What happens to the average citizen, the median quintiles, when it comes to the expenses, especially when you're talking about percentage co-payments, which can go easily to thousands of euros, and in a time of crisis, which can very easily be a burden to this average person in the median quintile, which is usually not covered by the protection to the poorer, but can easily turn into that side. What is the impact of these co-payments in this special median group, which is not, I'll say not the most disadvantaged, but usually forgotten as well? And the third one, if you have time, what is the impact of publicity and over-the-counter medicines in terms of the out-of-pocket expenditure? Does it have a big impact or it's residual?
Sarah, do you want to start?
Question. So that's a really great question, but I think the answer is no. I think that user charges, we just know there's just a lot of evidence showing they're a really bad instrument for moderating demand in an efficient way. Yes, they will moderate demand, but people reduce the use of necessary services as much as they reduce the use of unnecessary or wasteful services. So they're just a very blunt instrument, and they're not really addressing the real source of the problem, which is what's happening usually on the supply side.
Okay, does anyone want? Yes, Stefan.
Maybe I can add to that. There was one, exactly this example tried in Austria a couple of, maybe 25 years ago, as we are celebrating also 25 years of the observatory. I think that's quite a good example maybe. And there was exactly this, attempt to keep people away from hospitals with a user charge if you showed up without transferal. And in the end, it was just an additional source of financing and had no effect. And in particular, it was even increasing the question of equitable access to care, because we know that typically the pattern is different. So there's a bit of work on that. It was not scientifically very well looked at later on, but there is a bit of that, and it was abolished later on because it had no effect pretty much, except that it was really bringing people into poverty more easily and had almost no steering element or effect.
Okay, unless there's any urgent questions, we've got 3 for the price of 1 there, so we're very grateful to anyone from Portugal for giving us that final set. I just want to see, do any of the panel want to make any final comments before I make my very well-chosen final comments?
Maybe just to respond, because we have not answered all the questions, but maybe we can continue later on. But we did a study on over-the-counter medicines in Macedonia. We actually just published it recently, exactly for this reason, that, to understand what these medicines were for. And I think, and I would encourage countries to look much more into what is actually accessible through, over-the-counter without prescription, or some of them are with prescription but still not publicly funded. Because for 2 reasons: because there is sometimes a bit of an overestimation of the impact it has, and the other is that there is a bit of a shift from previously prescription medicines, which were actually publicly funded, now becoming available over the counter, and when we sort of ignored the impact of that, and there is an increasing impact, both in terms of unmet need, delaying seeking healthcare, and also in terms of financial hardship.
Well, thanks very much to the panel. You're not allowed to clap yet. You've got to wait till I've finished. There are, I think, a number of really important issues around this, and just starting with where we've been on user charges, there is no good argument for user charges except that user charges are a way of raising money. And they're a bad way of raising money because they do harm, but they're also a bad way of raising money because they're expensive to administer. And so user charges don't have a great role to play, but they're going to be with us for a long time. And I think the lesson here is you can make user charges less harmful, and you can be properly prepared that if they're introduced in a hurry, that you've got good plans for how you manage that process to minimize harm. The other side of this is the effects on unmet need. And I think, I always find it extraordinary. I go to the doctor and the doctor says, yes, you should have this, tee-hee, but you can't get it unless you pay for it yourself. What is the logic of saying, we will tell you with some great detail what's wrong with you and we'll do absolutely nothing about it? I mean, that's the underlying logic there. And yet, somehow, user charges for prescription medicines are almost everywhere, and they keep reappearing as being the instrument, and they make no sense, but they're going to be with us, and I think the lesson from here is you can mitigate the harm very considerably and make them less harmful. It doesn't mean that they are not still ones that have high transaction costs, and I come back to the importance of that. But I think this session has given, at least for me, 2 things really. One is we are getting better and better at understanding what the implications are of different ways of organizing financing, and the work that my friends at the Barcelona office have been doing, I think, has given us much more precision and detail and a really good basis for having the national debates as well as the comparative debates. The other thing is that we really do need, I think, to be mature and sensible about how we control expenditure if we're not going to do it through blunt instruments. And I was very glad that we had this question raised earlier, because if the answer is anything anybody wants, they get, then we're going to get ourselves in a mess that people are getting things they shouldn't be getting. And we know there's a lot of over-treatment happens, but the problem is that over-treatment is scattered around in all sorts of complicated ways. So we really need to grow up and have proper public discussions and political debates around how we make these controls work. Finally, we're going to, as you go out, we're going to show you a short video, which I think is quite fun to see this, because it actually turns these abstract discussions into human beings. That's not the video, but that is a picture tells 1,000 words, but a video tells 10,000. So in a moment we'll have the video, and you're welcome to leave, but not until you've given a round of applause to everyone here. And before you complain about my bad timekeeping, it wasn't my bad timekeeping, it was your bad timekeeping for not all being seated at the beginning of this session. So blame yourselves for the outcome of this not being the perfect finish on time. I'm very embarrassed about what's happened, but thanks for your participation, and thanks again to the panel.
As we work towards universal health coverage, or UHC, we need to ensure that healthcare is accessible and affordable, so that everyone is protected from financial storms. Affordable access to healthcare is known as financial protection. It is not only critical for UHC, it is a sustainable development goal. Countries across Europe and Central Asia have made good progress towards UHC, but many people still experience gaps in coverage. This means they face barriers to access or have to pay out of pocket for healthcare, sometimes at the expense of other basic needs. In this way, out-of-pocket payments can push people into poverty. We need to find ways to reduce these payments, but we can't do that without the right information on where and why things are going wrong. We also need to know what to change to make things better. This is why WHO Europe has created UHC Watch, an online platform with data and analysis on unmet need, financial hardship, health spending, and coverage policy in countries across Europe and Central Asia. Designed for policymakers and advisors, academics, journalists, and civil society advocacy groups, UHC Watch makes it easy to find the evidence, resources, and good practice recommendations you need. You can visit the country profiles for a snapshot of who experiences unmet need and financial hardship, and the health services and policies that are responsible. You can use the indicator and policy explorers to get a better understanding of the current situation and to monitor trends over time. You can generate your own analysis, comparing indicators and policies across countries and exporting data and graphics. UHC Watch has the evidence and analysis we need to move us closer to universal health coverage. UHC Watch, tracking progress on affordable access to healthcare in Europe and Central Asia.
In case you were wondering where you can find this, this is going to go online only in December, at the time of the Tallinn conference. So you are all invited. Thank you very much for your patience, and have a very good gala dinner. Thank you.